In keeping with the provided history, the patient has cardiac enlargement, sternotomy wires, and dilatation of the pulmonary artery. There is also a right-sided chest tube and a small right pneumothorax as denoted by lack of lung markings and a visceral pleural line. Although the patient is supine, you could see the pneumothorax in a better way here with a visceral pleural line in between the ribs and no lung markings after that. However, this is not the reason I'm showing the case. The reason I'm showing this case is for the cardiac appearance. Here's a normal case for comparison. Note how the cardiac shadow is not surrounded by increasing lucency. And also note how you could see two different hemidiaphragms, the left and the right, without continuity. So in a normal case, the right and left hemidiaphragm should not appear continuous in the center. Now let's go back to our case. We see that there is air lucency that's well defined within a space surrounding the heart. This appearance denotes air in the pericardial space known as pneumopericardium. If sufficient air is present in the pericardium, both right and left hemidiaphragms appear continuous across the midline. This sign is called a continuous diaphragm sign, a sign of pneumopericardium. We learned from this case that in a normal patient, both hemidiaphragms should not be continuous. And if you see a continuous diaphragm sign, that denotes pneumopericardium. Thanks for watching. The abnormality may be difficult to see. However, for a keen eye, you'll notice that there is an ill-defined hypodensity in the right hepatic lobe. Such lesions are easier to see if you adjust the window, and this is what we call a hepatic window. The hepatic window is about a width of 150 and a level of 100. What we saw was a CT without contrast. Now let's look at the arterial phase. You could know that this is an arterial phase by seeing enhancement of the aorta and lack of enhancement of the venous system such as the IVC. The first thing we notice on the arterial phase is that the lesion remains hypodense, suggestive of a cystic component. The lack of internal enhancement, in specific lack of hypervascularity, excludes hypervascular metastases and hepatocellular carcinoma. Another observation is that this lesion has a thin enhancing capsular rim. The third observation, which is very subtle, is that there is enhancement surrounding the lesion on the arterial phase, suggesting inflammation in the form of hyperemia. Another subtle observation is that the fat surrounding the involved hepatic area is a bit stranded and has linear changes. This is what we call fat stranding. Fat stranding is a sign of inflammation on imaging. Notice how the fat at the mesenteric side appears to be very clean and dark. So whatever lesion we're looking at has lots of features that are supportive of inflammation. Now let's proceed to a portovenous phase, a more delayed phase after giving IV contrast, and as you notice, the enhancement of both the venous and arterial system is equal. I'll give you a chance to look at the portovenous phase. On this phase, the lesion is clearly cystic with no enhancement. It also has this multiloculated appearance and a clustered pattern. It's also more clear here that there is a thin rim of capsular enhancement. And interestingly enough, what we saw initially on the arterial phase as a surrounding area of hyperemia appears hypodense here. Such surrounding hypodensity on the portovenous phase is consistent with edema, which is another sign that tells us that the hepatic parenchyma is inflamed. All these features are consistent with an infection, which could be pyogenic, amoebic, or due to hydatid disease. Now, hydatid cysts have various appearances when they involve the liver, but the surrounding inflammation would be unusual. Amoebic liver disease may result in patients who are immunocompromised or traveling from endemic areas. which is not the case here. Add to that the most common location of amoebic disease is in the dependent right liver, and it would be unusual for amoebic abscesses to be multiloculated or have a cluster appearance. So if you combine the clinical presentation with the imaging features, especially those suggestive of an inflammatory nature, you'd reach a conclusion of pyogenic liver abscess. When liver abscesses are sizable, the treatment is that of antibiotic with drainage. Percutaneous drainage is done here under CT guidance, and it could be done using ultrasound or even surgically. This is an image showing an introduction of the needle into the lesion using visualization under CT. This is a follow-up CT after drainage, showing a decrease in the size of the abscess. The image also shows the same feature that we saw before of surrounding hepatic hypodensity suggesting edema from inflammation. Interestingly enough, the drainage catheter has mistakenly slipped outside of the hepatic lesion on the follow-up CT. At that point, the treating physician decided on removing the catheter and continuing the treatment with antibiotics, and this is the follow-up CT a few days later. And with antibiotics alone, you could see near complete resolution of the hepatic abscess. We learned a few things from this case. First, it's much easier to look for focal hepatic lesions adjusting your windows to a hepatic window. The second thing we learned is that you could look for secondary inflammatory signs that might help you with your differential diagnosis. The signs that we saw include hyperemia on the arterial phase, surrounding hepatic edema on the portovenous phase, and even fat stranding around the abnormality. We learned that hepatic abscesses contain no enhancing components. They also have a capsule that enhances, as well as an important sign to emphasize, which is called the cluster sign, which is highly suggestive of abscess, especially pyogenic abscesses. We also learned that radiologists have an important role in treating these cases by ultrasound or CT percutaneous drainage. For the sake of comparison and to go over the differential diagnosis of cystic hepatic lesions more extensively, check our Radiology Bits YouTube clip number 14. Thank you for watching. Please feel free to send us your comments. See you later. This is a quick case to emphasize a few rules that we always talk about when we look at chest radiographs. The first rule is that the density on each side of the midline should be equal, especially in the retrocardiac areas. In this case, there is an asymmetric appearance of the retrocardiac area with a density that is seen on the left side. The second rule is that the hemidiaphragm should be well defined without obscuration. Notice the right compared to the left. And as you see in the area where we saw the opacity, there is partial obscuration of the medial aspect of the left hemidiaphragm known as a silhouette sign. You should never shy away from a lateral chest radiograph. It actually makes your life easier, and the abnormality suspected on the frontal film is seen here. One of the rules that we always emphasize on the lateral chest radiograph is that the density should decrease over the spine as you go from above below. In this case, the density in the lower aspect over the spinal region is increased, and this is known as the spine sign. This confirms your finding on the frontal radiograph as a lower lobe abnormality. So we learned from this case of left lower lobe pneumonia 3 big things. First, the density on each side of the midline, especially in the retrocardiac region, should be equal. Second, the diaphragm should be well defined, and if you see obscuration, this is a positive silhouette sign. The density over the spine on a lateral chest radiograph should decrease from above below, and if that's not the case, this is a positive spine sign for lower lung abnormality. Thanks for watching. This is a young patient who presents with right flank pain. So a CT scan of the abdomen and pelvis without contrast was performed. This examination is very common, also known as CT-KUB, kidney, ureter, bladder. This is done to assess for stones in the kidney or the collecting system, and since stones are calcified, we do not give IV contrast. Giving intravenous contrast could obscure underlying calcified stones. Now looking at this patient with right flank pain, you'll see no high densities within the kidneys or the collecting system. One of the things that we emphasize to juniors is that you have to be systematic in your approach and to look at everything. By everything, we mean everything, and that includes the visualized lower lungs. So let's change the window here. As you see, the main abnormality is a spontaneous right pneumothorax in this young male patient. And this is his subsequent chest radiograph showing a visceral pleural line and lack of lung markings beyond that line, consistent with the expected pneumothorax. So the quick teaching point is to look at everything on a CT scan, and that includes the lower lungs on a KUB CT examination. Thanks for watching.